Welcome to our Winter 2016 CPTA Gen webinar. My name is Leo Brando, and we are using a program called GoToWebinar to webcast this session. Before we begin, please allow me to go over some housekeeping details to assist in everyone's participation. Number one, for our Q&A session to be conducted at the end of the webinar, if you would like to ask a question verbally, we will open the mics per center to give you the word and the stage so that you can make your questions. If you're following the webinar individually, please click on the hand button found on the side of your control panel to raise your hand and be unmuted. You can also type it into the question box on your control panel to send me the question, and I will bring the question forward to the presenter. Number two, a quick message for the Sick Kids team in the clinic conference room. Please, during the Q&A session, we kindly ask you to come to the microphone in the podium so that your question can be heard clearly by all. The microphone is the white microphone. Number three, at the end of the session, an evaluation survey will appear at the end of the webinar. Please take a minute to complete the form. The survey will also be sent in a follow-up email to everybody. If you require any assistance during the participation of the webinar, please enter your comments in the question box, or alternatively, please call me at 416-813-7654 extension 205401. Now, please allow me to introduce our speaker, Dr. Murray Tressler. Dr. Tressler is a retired assistant professor of family medicine in Queen's University and associate professor, also of family medicine, Northern School of Medicine. He holds an MD degree by University of Toronto, where he did fellowship in family medicine, and he also holds an MBA from the University of Toronto. In his 50 years of clinical practice, he developed special interests, particularly on the management of warfarin in Canada. I should remind the audience, especially the pediatric treaters, that on any given day, somewhere between 250,000 to 300,000 adults are taking Coumadin. So his interests encompass improvement of warfarin management using computer decision support software, point-of-care INR testing, and patient self-management programs. And from his experience that he'll share with us in the care of adults, and also with collaborations he's had with the Stollery Children's, we'll be learning about how to improve the management of pediatric patients on Coumadin. So with no further ado, I have the pleasure of giving him and introducing to his lecture, Optimizing Warfarin Management in Canada. Thank you very much, Dr. Tressler, and the floor is yours.
Thanks very much, Dr. Brando. I appreciate this opportunity to talk to your colleagues about improving warfarin management in Canada. As Dr. Brando mentioned, I'm a family physician and have had an interest in warfarin management for most of my career. I'm the Vice President of INR Online Canada Limited, which is a not-for-profit company that was set up mainly to bring warfarin management tools into Canada, and in particular a piece of software called INR Online that we sourced from New Zealand. In the past, I've given a lecture for Roche Diagnostics Canada Limited.
Murray, if you wouldn't mind, when do you want to start showing your slides? Perfect. Click on the slide. Thank you.
Okay. Okay, are we in better shape there now? Okay. Sorry for that. Can you hear me all right? Hello?
Yes. Thank you very much.
Okay, very good. So the learning objectives of this talk are, number one, to revisit the standard of care for warfarin management in Canada. Two, to share the experience of the Canadian Pediatric Centre of Anticoagulation Excellence. Three, to provide a closer look at the direct oral anticoagulant clinical trial results. So let's start off with a case. So this is Sally. She's 15 years of age, very intelligent young lady. She's on long-term warfarin anticoagulation for congenital heart disease, and she has some questions for her doctor. Her first question really relates to her standard care warfarin management program. She wants to know initially, why am I on warfarin? The doctor explains, really to reduce the incidence of clots to the irreducible minimum in the safest and most cost-effective manner. Sally complains warfarin is inconvenient, and she goes on to explain how she actually has her warfarin managed. So it involves basically driving with her mother or father to the local hospital laboratory where a venipuncture is carried out. That blood sample is then transferred by a vehicle to a regional laboratory where it's processed. The INR result is then faxed over to her physician, and at the physician's office, the staff pulls her chart. The physician looks at her past INR results and her warfarin dosing, and then either using a paper algorithm or using his or her clinical judgment, phones through to Sally via an office staff member, and often it's Sally's parents who receive the message and relay it on to Sally as to what warfarin dosage she's to take. So the doctor admits, yes, standard care is a long supply chain that's inconvenient, it's expensive, it's prone to error, and it provides warfarin dosing delays, sometimes in the order of days and occasionally up to a week. And as an aside, my own mother had an INR of 7, and it really took a full week before the physician phoned her. Fortunately, we intervened in the interim thanks to a call from the laboratory. Alternative solution. Sally says, my uncle is on dabigatran 150 milligrams. He says it's as good as warfarin and it doesn't require any monitoring. Is dabigatran really as good as warfarin, Sally asks. The doctor goes on to explain, in recent large randomized control trials, the DOACs, dabigatran, rivaroxaban, and apixaban were found to be non-inferior, or in some cases superior to standard care warfarin at mean TTRs below 65%. And we emphasize that mean TTRs below 65%. Dabigatran 150 milligram was one of the DOACs deemed superior to warfarin at a mean TTR of 64% in the RELY trial. Can I try dabigatran? Well, the DOACs were trialed on senior citizens, not children in the main, and the DOACs were trialed on patients with atrial fibrillation, not congenital heart disease. So no, you're not a candidate for a DOAC at this time. Monitoring. Why do we need warfarin monitoring anyway? Monitoring is a serious issue. In older adults, medication non-adherence accounts for 26% of hospital admissions, 20% of preventable adverse drug events in community settings. It would be useful for all oral anticoagulants to have a monitoring test to assess the degree of anticoagulation, particularly in emergency, and adherence or compliance with warfarin dosing. A recent study was done in New Zealand that looked at all of the prescriptions for dabigatran entered into their national pharmacy tracking system. And it was found that only 8% of patients on dabigatran take it 100% correctly. That means basically 92% are not taking it correctly or not taking it at all. Note, the DOACs have a short half-life of 8 to 12 hours versus 72 hours for warfarin. So interruption of treatment regimens can lead to serious adverse events. This paper was presented by Dr. Paul Harper at the ISTH conference in Toronto this past June. Here's a case report and an example of what can happen. This is from Dr. Neil Davidson from Penticton, BC. Dr. Davidson is a neurologist who deals with a large volume of strokes. He had an 80-year-old female patient present with a hemispheric stroke. And he said to her, "I thought you were on dabigatran, Martha." And Martha said, "Yes, doctor, but I'm a little old lady and I thought a dose of 2 pills a day was too much for me. So I only took 1 pill a day." So this 1 pill reduction led to a large hemispheric stroke. So the bottom line here is you can't fix what you're not able to monitor. Her GP had no idea Martha wasn't taking her medication properly. Warfarin is also monitored for 2 other reasons. 1, to calculate the dose of warfarin correctly, and 2, to calculate the optimal date of the next INR test. And Sally, as you know, the INR means International Normalized Ratio. TTR. If dabigatran is approved for congenital heart disease by the time I'm an adult, should I switch? Perhaps if DOACs are approved for congenital heart disease, but it should depend on your average INR time in therapeutic range, or TTR. The average INR time in therapeutic range is an important measure of the quality of warfarin management. It's very much like a hemoglobin A1C in diabetes. And we wouldn't conceive of treating diabetes without knowing what a patient's hemoglobin A1C is, and yet we're treating patients on warfarin every day with no clue about the quality of our treatment. Most warfarin in Canada is managed without measuring TTRs, and the reason for that is we use paper systems, and we cannot calculate the TTR manually without great difficulty. It's a 4-step mathematical calculation, and it really requires the use of a computer. So if we're going to measure TTRs on all of our patients, we need to switch to a computerized system. What is the standard for TTR? Currently, the international standard for TTR is 60%. In my opinion, this is far too low given the present technology that is available. Why is TTR important? If the INR is below the target range, the patient is at risk of thromboembolism. If the INR is above the target range, the patient is at risk of hemorrhage. And it should be noted, the risk increases exponentially in both directions. Sally says, what is the mean TTR for standard care warfarin management in North America? Doctor replies 54%, and in Western Europe it's 67%. This is data from the RELY-AF registry, and it's INR control by region. As you can see, North America is 54%, and as we mentioned, Western Europe is 67%. But look at some of the other countries. They're as low as 35%. The TTR and the DOAC trials. What were the mean TTRs for the standard care warfarin control arms in the DOAC clinical trials? The mean was 60%. RELY, the trial for dabigatran, was 64%. ROCKET-AF, the trial for rivaroxaban, was 55%. And Aristotle, the trial for apixaban, was 62%. And the mean amongst the 3 studies was 60%. With so many patients, what was the range in mean CTTRs, or the TTRs for the various centers? Well, for instance, in the RELY trial, the CTTR range was 44% to 77%. Canada was 71%, but Taiwan was as low as 44% and Sweden as high as 77%. I guess the question here is it reasonable to compare Canada at 71% with so many countries that have mean TTRs that are much lower than Canada's? Thought break. Canada is a repository for the RELY trial for dabigatran data, and yet the Canadian dataset has never been published. Why is this? I asked Dr. John Eichelboom at McMaster exactly why this has happened, and he told me basically it was because we have a small sample size and the statistical significance is not very robust. I think we all understand small sample size. I think it's important, however, that we actually see the data. DOACs versus warfarin at TTR is greater than 64%. So Sally asks, if my TTR is greater than 64%, will I have a lower risk of stroke or systemic embolism than if I were on a DOAC? Doctor replies, we don't know. There's no RCT evidence on DOACs versus warfarin at a mean TTR greater than 64%. The DOAC trials were industry-sponsored and probably purposely trialed against standard care warfarin management rather than long-established, well-managed warfarin management systems. For example, Germany's patient self-management program with a mean TTR of 80%. But what we do know is that dabigatran 150 is the most effective DOAC in preventing ischemic stroke and atrial fibrillation. And this is from Stuart Conley and McMaster. However, in the RELY trial sensitivity analysis, once the TTR in the warfarin arm reached a TTR greater than 72.6%, warfarin appeared superior in preventing ischemic stroke. The statistical limitation is a small sample size. And here is the data directly from the Lancet 2010 article. So here we have dabigatran 150 at a TTR of greater than 72.6% with a sample size of 1,500 patients, and the rate per 100 person years is 1.17 versus warfarin at 0.97 with a similar size sample. So the advantage of warfarin over dabigatran in preventing non-hemorrhagic stroke and systemic embolism is an advantage of 21%. Improving warfarin's TTR. If my TTR on warfarin improves, will I have a lower risk of stroke or systemic embolism? Absolutely. This is data from the SPORTIV 3 and SPORTIV 5 trials. And basically, it looked at poor INR control, poor TTRs below 60%, and good control exemplified as TTRs greater than 75%. And here we can see dramatic reductions, excuse me, in adverse events. Stroke or systemic embolism, reduction of 49%. Ischemic stroke, reduction of 45%. Hemorrhagic stroke, 70% reduction. Systemic embolism, eliminated. MI, 55% reduction. Death from all causes, 60% reduction. And major bleeding, a reduction of 59%. So doctor, if I can improve my TTR, warfarin is likely to be more effective and safer than a DOAC. How can we improve my TTR? Well, there are basically two ways. We can improve the methods by which healthcare professionals manage warfarin, or secondly, we can improve the methods by which patients can play a role in managing their own warfarin. And it depends upon improved government funding for both systems. Let's look at healthcare professionals. What can healthcare professionals do to improve warfarin management? Point of care testing is the first tool. First, replace venipuncture and standard lab testing with point of care testing. This is an example of a point of care device. This is a CoaguCheck XS system from Roche. Here we see the test strip being inserted. The patient pricks finger, applies a drop of blood to the strip, either on the top or at the side. The QC is passed, and the INR is displayed on the screen of the device. It's easy. There's no arm bruising. The whole process takes about 2 minutes from the time of testing the patient to getting the INR result and being able to give the patient warfarin dosing instructions. Compare this to the standard care model, which took hours, days, and in my mother's case, a week before she got her results. Secondly, This ensures access every time. A finger prick can always obtain a sample of blood, as opposed to a venipuncture where veins are sometimes difficult to obtain. What about accuracy? This has been looked at by Mary Bauman and her colleagues at the University of Alberta, and QuagaCheck XS was appraised at generating an accurate and precise INR measure in children when compared to laboratory INR test results. This is true in adults as well. The only diversion in values occurs at relatively high INR values in the range of 7 to 8, in which case the INR should definitely be repeated in a hospital system. Computer decision support software. So the doctor said, secondly, replace paper-based warfarin management systems with computer decision support software. And just as an aside, although I'm involved with INR Online, I really have no bias on this. All I'm promoting is that we go to a computerized system, whether it's one you build yourself in your own institution or one of the ones that are available in the marketplace. The most important thing is let's get computerized and let's do away with our paper systems. So computer decision support software is an evidence-based solution, and in this case I'm just using an example of INR Online. It mathematically calculates a suggested dose of warfarin and the date of the next INR test. It mathematically calculates TTR for the patient and the practice, provides a printed warfarin dosing calendar for the patient that they can take home, or they can also visualize it on a screen on an iPhone or a computer. Provides an audit trail for the healthcare professional. It asks 4 safety questions prior to every INR input. And I'll guarantee you, most physicians in Canada never ask these 4 safety questions, but they're important. The first question is, have you missed any warfarin doses? The second question is, have you started a new medication? Perhaps the patient's gone to a walk-in clinic without the knowledge of the physician. Have you had any bleeding or bruising? And the fourth question is, have you been admitted to hospital or been to the emergency department? And here we're looking for thromboembolism in particular, but also for hemorrhage. These are examples of other systems available in the world. Auricula and Jornalia are 2 Swedish systems, and last January at this time I was in Sweden and met with a number of Swedish physicians and discussed these systems. The TTR in Sweden is about 75%, and most of the country actually is on this platform. The second example is INR Star, which is a product not too unlike INR Online. It's in use in UK in 2,500 GP clinics, and their TTR runs at 80%. 4S Dawn is a large server-based system that is used fairly extensively in the UK and in some installations in Canada. INR Online is available in New Zealand and Canada, and in both settings, in the hands of healthcare professionals, our TTRs run at 75%. In New Zealand, it's installed in 160 community pharmacies. PharmaFile is a Canadian product, and it's used in a number of large anticoagulation clinics. And then, of course, there are other in-house programs that have been developed, particularly in university centers in Canada and elsewhere. Most computer dosing software used in conjunction with INR point-of-care testing by a healthcare professional achieves a TTR of 75%. So what's the evidence backing up computer-assisted dosing? Well, it's grade 1A, which is the highest level possible. So the recommendations from the British Committee for Standard in Hematology are for patients on warfarin, computer-assisted dosing is superior to manual dosing. An example of how CDSS works. Well, the equipment is basically an INR point-of-care device, as we've discussed, and computer decision support software, which calculates the warfarin dose and the optimal day of the next INR test. In terms of patient advice, the patient is given a dosing calendar at the time, which is printed off for the patient to take away. And the importance of this is there's an opportunity here for the healthcare professional to ensure that the patient clearly understands the warfarin dosing instructions. This is far better than leaving a message to one of the patient's siblings on the phone because you can't reach the patient's parents or the patient himself or herself. The GP is informed or the physician is informed immediately for results that are out of range. And the INR and lines algorithm, if the INR is below 1.5 or over 4, then the patient's physician is alerted, and the physician then can work with the healthcare provider, the nurse, the lab tech, or pharmacist who's doing the testing to adjust the dose or day of the next test. On the left is an example of the warfarin dosing calendar, and as I say, this can be printed out or it can be actually picked up on the iPhone. The patient in a patient self-management scenario can log into the software and access their own treatment calendar. On the right-hand side is an INR report. At the very bottom, you'll see time and range by days. This is your TTR, and it's basically calculated on the last 5 tests. Above, you'll see the overall days in range, time in range by days at 92.3%. And so in this particular case, that's since inception, and you'll see that that takes into account the initial dip in the INR results on the accompanying graph. So the results are depicted graphically, and they're also depicted in a tabular form. And so from a medical legal perspective, there is a complete audit trail of the date of testing, whether or not the patient came in on time or not, the INR and the warfarin dose, and the date of the next recommended INR test. So using both INR point-of-care testing and computer decision support software improves TTR as well as calculating and tracking the TTR. This is the CPAM study from New Zealand. So CPAM stands for Community Pharmacist-Led Anticoagulation Management Service. And the mean TTR improvement in this study jumped from 61.8% pre-study to 78.6% post-study at the 6-month point. And the study used QuagaCheck XS in conjunction with INR Online. The TTR actually moved higher, and by a year was over 80%. In New Zealand, they did an audit study on INR Online to see what the TTR was in the real world. And pharmacists in this study, as I mentioned, there are 160 pharmacies involved in New Zealand. The TTR was 75.1%. There were a number of physicians who are also operating INR Online in their own surgeries, and their TTR was 67.4%. Now, I think most physicians would think they would probably be able to exceed the 75% TTR of the pharmacist, but unfortunately, physicians tend to override the computerized system, and in so doing, undergoes the patient. I think this relates to the physician's innate fear of hemorrhage or bruising. So the advice here is let the computer do the work, and the physician should focus basically on dealing with INRs below 1.5 or over 4. This was a study of 3,660 patients at 60 sites over a 3-year period. Patient self-testing. So Sally says, can patients test their own INRs at home? This would obviously be much more convenient for Sally. Yes, they can, and their TTRs improve. There's a large study that was recently published in the United States called the STABLE study, and the TTR in that study was 73.9%. The study was carried out on 68,000 patients registered in the Alere company's database. It involved over 3 million INRs. Now, the way it works in the United States is that the patient in the program tests at home, then they phone their INR result into a Lear, and a nurse provides the patient with a warfarin dose. Patient self-management. Can patients dose themselves too? Yes, they can, and their TTRs improve even further. Patient self-management. In Germany, patients have been taught to manage their own warfarin for over 25 years. This was initiated by a lab technologist who had a mechanical heart valve and got tired of going to the lab for her INR results. So she devised a system whereby, through the assistance of Roche, she was able to manage her own INRs at home with a very crude version of the QuagaCheck. And she then went on to petition the German government to support the program, and the program has grown over the years, and at the present time 200,000 German patients manage themselves. So we're looking at a total of maybe 250 to 300,000 patients on warfarin in Canada at the present time, and here we have in Germany a group of patients that almost represents our entire warfarin management program, and their mean TTR is 80%. So let's visit Dr. Stefan Kress in Landau, Germany to see how it's done. I visited Dr. Kress in 2014. So here is Dr. Kress, and he's on the left in his clinic in a hospital in Landau, Germany. And he basically uses small groups, so he educates about 5 to 6 patients at a time using a very simple set of flip charts with excellent illustrations. And the patients are taught basically on a program that goes from Monday to Friday, 3 basic modules. The first module is on warfarin. The second module is on how to use the QuagaCheck XS machine. And the third module is how to manually dose themselves with warfarin. So the program on Monday is about a 4-hour program, and as they pass each segment, they have a little certificate, which you can see on the right, and they receive a stamp. So this is typical German precision. And at the end of the formal process, the patients are given a QuagaCheck XS and are told to take it home, and they're to test on Tuesday, Wednesday, Thursday, and Friday. And on Friday they return, and they're given a written test plus a practical test to make sure that they understand precisely how to use the equipment. And once they've passed the examination, they're given a patient certificate. Now, this certificate entitles them to the loan of a point-of-care device. So instead of purchasing the point-of-care device, it's provided to the patient on a loan basis, and when the patient is done with the machine is returned back to the hospital, and it is then sent on to Roche for refurbishment and then reissue. So in Canada, the cost of one of these machines is about $500, and in Germany, they reissue the machine for about $100, saving the system a huge amount of money. Dr. Kress's advice to his German patients is, it's like the Autobahn. You want to stay in the middle lane. So the middle lane in warfarin therapy is a TTR between, or an INR between 2 and 3. This is the data behind the claim of a TTR of 80%. So this has been well researched and is consistent with the large numbers of German patients in the program. So thought brief. Boehringer Ingelheim is a German company that produces dabigatran. And despite the fact that it's a German company, and despite the fact they were well aware of the German patient self-management program, they never trialed dabigatran against the German PSM program with a TTR of 80%. And the question for many German physicians is, why didn't they? This is a study from Carl Hennigan, and he looked at the patient self-management program with respect to the reduction in adverse events and found there was a 58% reduction in thromboembolism, a 25% reduction in mortality, and a 14% reduction in major bleeding. Of note is the fact that Dr. Kress uses only 1 milligram warfarin tablets, which is consistent with the German patient self-management program. And this is to allow smaller increments in dosing and also to prevent confusion between different colored tablets. The patients test typically once a week and see their family doctor every 3 months. Most of these patients who have atrial fibrillation or mechanical heart valves probably see their physician every 3 months anyway, so there's probably little incremental cost to the system by having them come in every 3 months. German medical insurance pays for the test strips and for the education program. Tight INR control. Why do German PSM patients test weekly? To improve the tightness of INR control, which leads to much lower adverse events. Tight INR control is clustering as many INRs as close to the target INR as possible. The objective is to prevent wide-ranging outliers due to the exponential rise in adverse events. The DOAC RCTs generally have poor tightness of control. And so this is why there was a high rate of intracranial hemorrhage and in some cases major bleeding in the warfarin arms of the DOAC trials. Many of these patients were not brought back on a timely basis to have their INRs repeated. And this, I think, reflects the lack of robustness in a number of the participant countries' healthcare systems. And I've spent 9 years working overseas, and I'm well aware and acquainted with some of those deficiencies. Hemorrhagic stroke. This is a very important table. Let's go back to 2003 when the SPORT-T3 trial was published. The TTR in that trial was 66%. The number of participating countries was 22. And the hemorrhagic stroke rate was 0.4%. In 2005, the SPORT-T5 trial trialed the same drug, zamilocatran, that was trialed in SPORT-T3 versus warfarin. The TTR was somewhat similar at 68%, but this time only 2 countries are involved, Canada and the United States. And the hemorrhagic stroke rate dropped like a stone to 0.1%. The reason is that SPORT-T5 had an exceptional tightness of control factor. 83% of INRs were between 1.8 and 3.2. Following that, the remaining DOAC trials were carried out. Now, my question is, did the pharmaceutical industry have some insight as to what happened between SPORT-T3 and SPORT-T5? And I think they definitely did. What did they do? They doubled the number of countries, and what happened? They doubled the hemorrhagic stroke rate in the following trials compared to SPORT-T3. So it's a huge difference between the hemorrhagic stroke rate in SPORT-T5 and the remaining DOAC trials. We can see this trend again in intracranial hemorrhage rates in the same trials. And again, when we look at the warfarin arms, the warfarin arm in SPORT-T5 had half the intracranial hemorrhage rate that the remaining DOAC trials had. And it's important to remember that the spontaneous intracranial hemorrhage rate is 0.15% in adults. And this was data from Mass General in a 70-year-old plus population. So frequency of INR testing does matter. When do you want to catch your out-of-range INR? So the point is, if your INR is trending high, if you don't do an INR test within a week or two, you may not catch that INR until the patient presents with a bleeding event. Similarly, if the INR is trending low, we get the same risk of exponential increase in adverse events, i.e. Thromboembolism. Apps. I like apps for my iPhone, says Sally. Is there an app to help me remember to take my warfarin? Yes, there is. It's a new free iPhone app called INR Log. It's available to anyone at no charge. So this is a screenshot of INR Log, and what it does is it measures the TTR. So basically the patient enters their tablets and their dosing regimen and any past INR results. And then every time they do their INR, they put in their result and they put in the warfarin dose that they're to take. So it tracks the TTR, tracks compliance, and it tracks the INRs and the warfarin dose, and it reminds the patient to take their warfarin daily and test their INR on the date due. And as I say, it's free from the App Store and can be downloaded on an iPhone. Unfortunately, there's no Android equivalent at this time. What about kids? Can we manage our own warfarin? I suppose we're too young, says Sally. So now we're going to talk about kid clot. The best warfarin management in the world is done by kids right here in Canada. And the TTR is greater than 90%. And perhaps most of you have seen this article, which was published in Thrombosis Research by Mary Bauman and Patty Massacott in Edmonton. So this is the Empowered study, and it's a study of the Edmonton Pediatric Warfarin Self-Management Program, KitClot. So what were the results of this program study? Number 1, no clots. Number 2, no bleeds. Number 3, no medication errors, and a TTR that exceeded 90%. Now, it was a small sample size, but small sample sizes, I think, are typical of most pediatric programs in Canada, and it utilized I think, the majority of patients they had available. The average age was 6 years, and the study period was 2.7 years, which is comparable with the study period in the DOAC trials. Are there any advantages to patient self-management programs like KidClot? Well, absolutely. Number 1, these programs use the cheapest oral anticoagulant on the market, warfarin. And warfarin's been around for 60 years plus. It's proven to be safe. It certainly has its challenges, but we all know what those challenges are, and those can be managed. Patient self-management requires the minimum of healthcare professional labor. This is the most expensive component in long-term oral anticoagulation management. And if you can eliminate or reduce this, particularly in children, if they're going to be on warfarin for their lifetime, if you can eliminate healthcare professional content, this is a huge saving to our system. It also provides the lowest rates of adverse events and the highest TTRs. It's the most convenient warfarin management option. It allows the patient to test at home. It also allows the patient freedom to travel. For seniors, this is huge. Patients can no longer travel, on a cruise or go to Mexico or the United States for a holiday if they have to appear on a regular basis at the lab for their INR testing. 24% of the adult population can manage PSM, according to an OTAC study from the Ministry of Health in Ontario. The percentage is much higher if you apply it to caregiver management. So, for instance, in long-term care facilities or in home care programs where nursing staff or family members can assist in testing, we can increase the number of patients managing warfarin on their own at home. Government, what's their involvement? Well, this is an annual PSM cost analysis, and we'll go through this column by column. So let's first of all look at the cost of the Ministry of Health. And as an aside, the text in red refers to things that are not in place right now but need to be in place to make the system work properly. So Warfarin is at a cost of about $240 per year to the system for patients who are covered under drug benefit plans in Canada, or also for patients who are covered by private insurance. The benefit is it's the lowest cost oral anticoagulant option, as I mentioned. Savings to the system. The cost of a stroke is $50,000 for the first 6 months. And this is according to BERS, a study that was done by the Institute of Clinical and Evaluative Studies in Toronto. The cost of a DOAC is somewhere between $1,100 and $1,300 a year. Now let's look at the patient. So for the patient who doesn't have coverage under a private scheme or under a government scheme, the cost is $240 a year. Compare that to the cost of a DOAC for the patient. The cost of a device, is typically around $500 a piece. That price drops to around $400 for higher volume purchases. The lifespan is 5 years, so the cost of the device is about $100 a year amortized over 5 years. Test strips. If a patient were to test every week using the Roche test strip, and that included INR online, the cost would be $364 a year. The benefit is it has the fewest adverse events, so this is the most important thing for the patient, and it provides the patient with freedom and point-of-care convenience with no failed or painful venipunctures. It also saves them the cost of travel and parking, which is at least $520 a year for most patients. And thanks to Jim Flaherty, the device is now tax deductible. For the family doctor, the benefit is fewer adverse events, and the family doctor is now only involved in out-of-range INR issues. So for INR in line, those are INRs below 1.5 and over 4, and of course any adverse events. And the biggest savings is in time. 90% of INRs can be handled by a computerized system with a healthcare professional rather than a physician healthcare professional. The Ontario government projected PSM savings in an Ontario Health Technology Assessment Series in 2009 at $1.2 billion over 5 years. Now that's assuming that all 132,000 patients in Ontario would be on patient self-management, and obviously that's not true. From their own data, they estimated around 24% would be eligible. But as I said, if we use caregivers and other ancillary help, we can increase that number. And if we looked at 132,000 patients as being about half of the number of patients in Canada on warfarin, then I think we could estimate that a national savings could be achieved at $1.2 billion over 5 years in Canada. So a thought break. Every province is running deficits in healthcare. We could be saving money and saving lives by improving warfarin management. Yet so far, little is being done. Why is this? Conclusion. So in this talk, we've looked at standard care in Canada and North America at a TTR of 54%, and we've seen that migrate to the DOACs at TTRs below 65%, and then healthcare professional and patient self-testing programs using point-of-care devices and clinical decision support software achieving TTRs in the range of 75%, and then onward to patient self-management programs in Germany achieving a TTR of 80%, and now finally the KIDS program in Edmonton with a TTR exceeding 90% with no adverse events. So what is our objective? Our objective is to move from a TTR of 54%, employ the tools that are available, and get the government to support us in this initiative, and move on to patient self-management programs where applicable and healthcare professional programs where not, to improve our national TTR. Critical success factors: adoption of best warfarin management practices by pediatric and adult anticoagulation management centers in Canada. Secondly, a recognition of best warfarin management practices by academic teaching centers in Canada. And thirdly, appropriate funding by provinces and federal healthcare agencies for best practice warfarin management tools. I think there's a great opportunity here for pediatrics to lead the charge. With this wonderful benchmark in Edmonton, I can see how this could be spread throughout the pediatric community in Canada, and hopefully from there migrated into the adult world. The adult world is a little more difficult because it's currently obsessed with the DOACs. I think that warfarin, when it's well managed, as we've just discussed, can certainly exceed the reduction in adverse events that we all seek in long-term anticoagulation management. So thanks, Doc. So there's the story, Sally. So I guess we can move on now to some questions. If you have any direct questions you want to send to me, this is my email address, and certainly that's my phone number, and I'm happy to respond to any of your questions. Thanks very much for the opportunity.
Thank you very much, Murray, for this really thought-provoking sharing of your thoughts on the issue of oral anticoagulation, the use of warfarin in contrast to DOACs. Let me open to some centers now. I'll go to Calgary, or to Alberta rather. Let me try to open. I have Brenda Gallagher listed, but it's really the Calgary Center, I suspect. The microphone is open. Any question from Calgary? No question. We'll move forward by opening the floor. Now we're going to go to Montreal. It's west to east. Let's open the mic of Montreal. Montréal, vous avez quelques questions? No? And then we open the floor for, I have several questions, but I'll open the floor to my colleagues here at Sick Kids. Are there any questions? Please come to the white mic. If no one is coming, Murray, let me ask you, I'll start with two questions. The first one, when we read the papers, not the ones with 200,000 German patients, but patients where the number, manuscript where the number of patients is relatively small, could there be a chance that we selected for the self-management programs the patients that are already the most motivated ones, and also the effect of having their INR handled by an anticoagulation clinic rather than perhaps, well, I can't say a general physician because you top everybody, but if we don't have Dr. Truslers throughout the country, that not necessarily the same benefits would be generalizable to other patients that are not necessarily so self-motivated as the ones included in this literature. That's question one.
I think that's a very good point, and you're absolutely right. So when we looked at these studies, and I think that Mary Bauman clearly indicated this, that there was a potential for selection bias in their results because they picked the patients who were obviously capable of handling the point of care device. And that's probably true to some extent in the German situation. What's interesting in Germany is 60% of patients are self-referred. So they find out about this program on the internet. So right off the bat, there's a selection bias there. The patients who do use the internet versus those that don't, and what does that infer about their mental capacity to begin with. But It's interesting. I was at the Thrombosis and Hemostasis Summit in Calgary, and I spoke to a nurse from Florida, and she was using point of care testing and had this amazingly high TTR. And I said, well, um, you know, how is it that you can manage this program with all of these old folks down in Florida? She said, the issue is if the patient can't handle the system, then they usually have a caregiver in attendance anyway, because they can't handle a whole bunch of other things in their day-to-day lives. And that caregiver is the person you train. So patient self-management then becomes a team approach. And I think that's where we're going. Um, but I think the other important thing is to look at healthcare professional programs like the one in New Zealand, where we've got 160 pharmacies, treating all comers, and the TTR is 75%. If our TTR is at 54%, and just by having a pharmacist or a healthcare professional, it could be a nurse or a lab tech, manage the testing and the computer program and getting a TTR of 75% instead of 54%, that's a huge improvement. And I think that's step one. That's where we need to go first. But I think in pediatrics, you have a little niche environment here where there are a lot of intelligent kids who can handle this technology very well. And I think you should capitalize on that.
My second question relates, if I followed you, our target, so that we would, according to the arguments presented, be better placed than in the use of DOACs if our TTR is above 75% by perhaps pursuing an anticoagulation model that would be computer monitoring generated with point of in alignment with weekly point of care testing. Let's say it was for us to pursue such a model. You have it seems that you have a lot of experience with this. Where do legal implications go as far as a potential mismanagement that occurs, that then someone can come and say, well, the computer generated what to do, and a back and forth? Do you have any comments to say about potential legal implications with so much technology involved?
That's a good question. Um, I think that in Edmonton, for instance, the patients enter their TTR or their INR on the computer program, but that computer program is being also monitored by the staff, so that in Mary Bauman's case, it's Mary Bauman and her group that are looking at these results and making sure that the management is in line. And I think the important thing there is they had no dosing errors in over 2.5 years. But I think that you're quite right, because in the United States, there's tremendous fear about just what you mentioned, and patient self-management programs are not widely in use in the United States. Instead, they use the patient self-testing program, which is much more expensive. And CADTH looked at this as well in Canada and deemed that PST was really not the recommended program because of the cost involved. So I'm not aware of any litigation in issues in Germany that I know of, but it's a different environment than North America. I think it'd be worthwhile asking Mary Bauman and Patty Massicott what their take is on the on the legal issues.
Mm-hmm. And your comment is very timely, because Mary just wrote us back to clarify that the study, even though it had a small number of patients, they did randomize patients to be on the patient self-management or not, and even the ones who had done poorly previously did much better while they were on the PSM program. So that, I guess, speaks for the strength of the program and the perks that it brings.
I think parallel too is diabetes management. I mean, we have uh, patients everywhere testing their blood sugars and adjusting their insulin. And in my practice experience, I've never heard of a patient suing on the basis of, you know, adjusting their dose of insulin incorrectly based on their blood sugar results. So.
I'm just going to ask if there are any further questions or comments from the floor at SickKids, given that I don't see anybody else, and I don't think we have them, and we're getting to a closure. I would thank again Dr. Murray for this great webinar, inviting everybody to come back in March for our next presenter, Pediatric Stroke and Sickle Cell Disease by Dr. Suzanne Williams. Thank you very much to all.
Thank you.